My name is Kevin Gaskin. I live and work and teach in SUNY Upstate Medical University in upstate New York. Today we'll be talking about POCUS for small bowel obstruction. We're going to start off with a case. A patient presents to the ED with abdominal pain. Based on this information, what do you think is the most likely diagnosis? A, B, C, D, or E? At this point, you may be a little miffed with me because you're probably asking yourself, how can I possibly answer this question? However, I'm presenting the information for this case in this fashion in order to get across 2 points. Number one, to show you explicitly that there may be some value to the much maligned history and physical exam because it provides discriminatory information. And number two, to introduce the concept of prevalence and its importance to medical decision making. Of course, without any clinical information, the only way you could answer this question is by knowing the prevalence of disease. And in the undifferentiated abdominal pain patient presenting to the ED, these are the top 5 diagnoses. Number one is nonspecific abdominal pain at 31 to 42%. Number two is acute appendicitis at 4 to 20%. Number three is acute cholecystitis at 3 to 11%. Number four is small bowel obstruction, also at 3 to 11%. And finally, kidney stone at 3 to 4%. So there's kind of 2 take-homes for me from this data for this lecture. Number one is, why is abdominal pain such an unsatisfying problem to pick up on the board from the ED? And that is because almost 50% of the time, you're not going to come up with a diagnosis, even with extensive workup, because it's nonspecific abdominal pain. And number two, for the purpose of our discussion, small bowel obstruction has, in general, low prevalence compared to the other disease processes. So let's try this case again, pretending that the patient is being evaluated not just by an ultrasonographer or a radiologist, but a real live clinician who obtains the following history. Now, based on this clinical information, what do you think is the most likely diagnosis? A, B, C, D, or E? And in this case, the answer choice is much more obvious. Again, I'm trying to show you the discriminatory value that an adequate history and physical exam provides to the clinician. So now what if the physician who was obtaining that history also had an ultrasound machine and obtained the following image? And as you can see, there's no longer any doubt to the diagnosis. The POCUS has clinched the diagnosis. And this clip is important for 2 reasons. One is, first, we see these dilated loops of bowel of differing calibers, and this is a specific sign called caliber jump, which is the hallmark sign or signature of SBO. And this means you have to have a thorough exam, because the precept is a negative exam presumes a technically adequate one. These lesions can be discontinuous, so you have to search through the entire abdomen using your lawnmower technique. Number two is the idea of cognitive unloading. So the problem facing the ED physician is that we take care of multiple patients, and the issue is that the human mind can only retain a certain number of elements within the short-term memory. So if you're able to close out these clinical decision-making moments in the room with the patient, then you're able to free up space and better take care of your other patients. And that is the revolutionary aspect of POCUS, because by wheeling this machine in, you're bringing in a technological adjunct to the clinical exam. And that is the power of POCUS. It's an ultrasound probe in the hands of a clinician at the patient bedside. The power comes from combining both the clinical exam and the ultrasound findings. Before proceeding to a discussion of the sonographic features of SPO and POCUS, I just want to point out 2 details about SPO. So some ED physicians tell me, I'm just not going to use POCUS for SPO because I'm going to order a CT. But there's an assumption there. The inherent presumption is that you're going to order the imaging on the correct patient. The fact is, that the clinical exam is neither sensitive nor specific for SBO. And in this paper from 1998, it's a German study, shows that SBO is frequently missed, in fact, 50% of the time on an initial exam. And the point is, it just relates to cognitive difficulties in making this diagnosis. And there's more to it. They found that with less historical detail elicited by the physician ordered the imaging incorrectly. In other words, there was no SBO. However, when they had more historical detail, they a higher percentage of time correctly ordered the imaging, and there was SBO. So the point is, we miss SBO in both directions. We send them home when they have it, and we order imaging on them when they don't have it. The second important fact about SBO is that there is the potential for severe complications, despite the fact that many of us think of it as a benign diagnosis. The fact is, 15% of these patients get admitted to the surgical service, and 15 to 30% of these patients have these bad outcomes from strangulation, bowel necrosis, which result in perforation, sepsis, and death. So our thought that it's a benign diagnosis is really just an availability bias, because most of the time we see that these patients do well with conservative therapy. Now, who is at risk for these complications? And it's increasing age, more comorbid illness, but also if there's a delay in diagnosis or decision intervention. And this is the part that I want to emphasize to you. This is where we as ED physicians can make a difference in care by, number one, making a timely diagnosis and commenting on whether the patient is already at a high-grade stage of obstruction. So now we're going to discuss the diagnostic power of different imaging studies available to us. So we're going to look at the imaging modality, and we're going to discuss them in terms of likelihood ratios. And I'm sorry if I'm creating flashbacks to medical school, or perhaps you never even learned about this stuff. Likelihood ratios combine sensitivity and specificity in one number, and they allow us to directly compare the power of different techniques, features, symptoms, or findings. I'm going to give you a little cheat sheet here. So positive likelihood ratio, and then how much it changes our post-test probability. So if it's 1, there's no change. If it's 2, it's positive 15%. If it's 5, it gets us a change of 30%. And 10, and this is the one I want you to focus in on, it gives you a positive 45%. This is decisive change in probability. Negative likelihood ratios function in a similar fashion. So 1 offers no change, no value. 0.5 reduces the possibility by negative 15%. 0.2, it reduces the possibility by negative 30%. And 0.1 is going to be decisive finding. It decreases your probability by negative 45%. So with that in mind, let's look at the different imaging modalities. So, everyone's taught in med school, you got to order abdominal x-ray. Is this really a good teaching? Well, positive likelihood ratio is 1.64, so it offers very little discriminatory value. A negative likelihood ratio is 0.43, so similarly, you're going to have a change somewhere between, negative 15 and negative 30%, so not a lot of value. How about POCUS? 9.55. Boom, I want you to look at that. That may be surprising to you. So it's almost 10. So it's seeing evidence for small bowel obstruction on POCUS is a very valuable finding. What about in reverse when you don't see it? Likewise, 0.04. This is very strong evidence going against it. So could you use POCUS with your physical exam to rule out SBO? Tantalizing idea. How do the radiologists compare? This is RADIUS. How does RADIUS compare to POCUS? 14.1. So a little bit better. Maybe this has to do with the degree of experience they have. However, 0.13. So that is not less than 0.1. So maybe less better at ruling it out. And that may have to do with prevalence because, if we're going in with an ultrasound machine, we already have a high suspicion that they have SBO, whereas radiologists are dealing more with all comers. Finally, CT. This is the donut of truth. This has got to be the best test, right? Wrong, 3.6. And that's surprising to a lot of people that you see. POCUS has more value than CT at ruling it in. How about it ruling it out? 0.08. Again, POCUS has more power at ruling it out. And why is that? Well, what does POCUS do really well? It visualizes fluid. And what is SBO? Fluid-filled tube. Finally, MRI. That's our best imaging technique, right? It's the flagship. This has got to be the best technique, right? Wrong again, 6.77. So a little bit better than CT, but you're still not achieving a decisive difference. And then 0.11. So fairly good at ruling it out. Now that you're convinced of the power of focus, you want to know, okay, what do I need to look for? And so right now we're going to go over the sonographic features of SBO, but I'm going to do it in a certain way. I'm going to discuss it in terms of the natural history of SBO. So maybe we can look for some features that are concerning for high grade or low grade obstruction, kind of structure how we're looking at our findings. So now we're going to discuss the particular sonographic features of SBO and focus. We're going to do this in a particular way. We're going to look at the natural history, and there's 3 stages. The first stage is stage 1, simple mechanical obstruction. So the first thing we're going to look at is the bowel. And like in the first case we saw, we're looking for dilated bowel, but it's in a particular relationship. So upstream from the obstruction, or what they term in the literature, the fulcrum, the bowel will appear dilated, and that's the hallmark sign of SBO. And then downstream from the obstruction, you're going to see decompressed bowel. If you can find that specific point, that's called the transition point, which is specific for SBO. And this is our, as we're doing our lawnmower technique, we're looking for that caliber jump, trying to find that area of discontinuous bowel. Next, we're going to be looking at the peristalsis, or the movement of the bowel. And in this stage, the bowel is still healthy, and it's trying to work against the obstruction. And so it's very vigorous and hyperkinetic looking. Next, we're going to look at the appearance of the valvuli. They are prominent. There's no objective definition of this. It's just a sort of subjective appearance, and you'll develop a feel for that with experience. And this also tells you something about the location, because these occur in the jejunum. And one final word on terminology. All these terms are the same, and they refer to the folds of the jejunum. Then we're going to look at the parietal walls. And in this stage, there's no thickening yet of the wall. Again, there's no consensus definition of this, but some benchmarks is the normal bowel is 1 to 3 millimeters. The important part at this stage is there's no vascular compromise. And so these patients are generally going to respond to conservative therapy. So if you see these features, you're more sure that this patient may have a lower grade obstruction. This description of the natural history and ultrasound features comes from a group in Italy that are radiologic ultrasonographers that did a lot of work on SBO. Next stage, which is stage 2, decompensated obstruction. And this is where things are starting to go awry. So you're going to start to see free fluid between the loops of the bowel, and that is because as the obstruction continues, the bowel tires out and it dilates and the walls thin, the fluid's going to transitate out into the abdominal cavity, and you're going to see it. Next, you're going to see a change in the peristalsis. So you're going to see the activity of the intestinal wall is ineffective, and you're going to see what's been described as a to and fro motion, or a back and forth motion. Now, a lot of ultrasound experts talk about this sign, and they mostly use it in a diagnostic sense. But if you look at it in terms of this framework, you can see that once you see to and fro motion, you're already in the decompensated stage. So the point I'm trying to make is that seeing to and fro motion has more than diagnostic significance, it has prognostic significance. If you see this, you should have a heightened concern for your patient. Next, you're going to look at the parietal walls. And again, as things back up and the bowel dilates, the wall is going to start to thin to be less than 1 millimeter. Again, there's no consensus definition of this, but it's a yardstick. The key feature of this is that time is running out, and someone, not you, a surgeon, needs to make the decision. Is this person someone who needs to go to early operative intervention, or is this somebody who might respond and have a trial of conservative therapy? So there's no vascular compromise yet, but it's impending, and a decision needs to be made quickly. Finally, is the third stage, which is complicated obstruction, and this is where there's high concern that there's already necrotic bowel. So in terms of peristalsis, you're going to see bowel that's akinetic, and it looks like dead bowel. The valvuli, thick, so no longer just prominent, but very thick, very hyperechoic, very easy to see. The parietal walls are now starting to thicken greater than 3 millimeters. And this is the stage where there's high rates of complication. Again, as I said before, at this stage, 15% of these of SPO patients get admitted, 30% have strangulation, and 15% with bowel necrosis go on to perforation, sepsis, and death. This is a surgical emergency. Okay, now that we've gone over that conceptual framework, let's look at some actual POCUS images. You're like, finally. But we're going to do this in a particular way. We're actually going to go through 6 cases. I'm not just going to hand this to you. We're going to figure out these features together. Okay, case number 1, and they're all going to be the same format. I'm going to ask you the question, does this patient have SPO? And then I'm going to show you an ultrasound clip. So here's the first clip. Okay, so does the patient have SPO? Well, first, you might be saying, well, there's some concerning features here. I see some free fluid. I see these thickened bowel walls, concerning for SPO, right? Well, the patient did not have SPO. In fact, the physicians were performing this study because the patient had ascites and altered mental status, and they were performing it to getting ready to do paracentesis. So the point is there can be confounders to your interpretation of your ultrasound exam if you haven't elicited the patient characteristics correctly. And this is the problem with being a radiologist. But you are not a radiologist. You can talk to your patient. And again, the power of POCUS is putting together the clinical picture with the technological adjunct, which is the POCUS findings. In case number 2, again, the same question. Does this patient have SPO? Here's the first clip. Here's the second clip. So does the patient have SPO? No, in fact, this is normal bowel. This is at the level of the duodenum. So what I'm trying to show you is up at the liver. The duodenum is very short. You very rarely see it. It does interfere with your gallbladder studies sometimes. Point is, it's smooth walled. And here you see this air fluid interface, and it interferes with seeing the posterior wall. And so that's a very common feature of normal bowel. And here is the case continued. So you didn't believe me that it was not a SBO. Here you see a loop of bowel and short axis, and the bowel is fluid and dual filled, and so sometimes you can actually see that posterior wall. And if you use the depth gauge on the side here, you can see that this loop of bowel just below the abdominal wall is less than 2.5 centimeters, and therefore unlikely to be SPO. And a comment on technique, there's a lot of wasted space here. She'd probably want to zoom in on that loop of bowel to measure it correctly. Okay, case number 3, again, the same question. Does this patient have SPO? Here's the first clip. And here's the second clip. Okay, so here you're seeing some features that are specific to the jejunum. You see these lines going across the bowel. That's called the herringbone sign. And then over here you have these kind of like teeth-like or piano key-like features, which are called the keyboard sign. Both of these indicate that you're in the jejunum. So probably the obstruction is either within the jejunum or just distal to it. And then you can also see that the diluted loops of bowel that define SBO. So I just want to go over that in particular because there are 2 patterns you'll see in the jejunum. One is these lines that go across, okay? And that's called the herringbone pattern because they look like fish ribs. And then the other part is these prominent knobs that look like piano keys, and that's called the keyboard sign. So both of these are consistent with an obstruction either within or just distal to the jejunum. And then the question is a subjective interpretation. How prominent and thick are they? Because that information has prognostic significance. Okay. Case number 4, does this patient have SBO? Okay, let's look at that again. And you can see that there are some features that are similar to the last case we just saw, and yet they are different. Number one, you can clearly see that the bowel is dilated. You can also see that there is no movement. This is akinetic bowel. And then you see these hair-bone structures, these hyperechoic lines going across the bowel, just like in the other one, but they are more prominent, more hyperechoic, more thick. You also see the keyboards on the right side of the screen there. Again, more prominent, more hyperechoic, thicker. So this is a very concerning ultrasound image. This is essentially you're looking at dead bowel here, and the CT was read as a high-grade obstruction. So the question is if a radiologist can call uh, a bowel obstruction high-grade, why can't we do the same thing on POCUS? It also shows you that, a lot of a central fact about herringbone sign and keyboard sign. So a lot of ultrasound experts talk about these signs as agnostic. But as you can see here, there's a prognostic significance too. The only issue is that it's subjective. It's just a subjective difference in the appearance of these two signs. They're just more prominent, more hyperechoic, thicker, but it's very concerning for a more advanced grade of SBO. So case number 5, again, does this patient have SBO? And now we're starting to look at some peristalsis here. So we're looking at the movement of the bowel, and you can kind of see this back and forth movement to and fro. So when you see this, yes, it's diagnostic of SBO, but it actually is prognostic because it places them in the second stage or decompensated ileus. Okay, case number 6. Again, same question. Does this patient have SBO? And here you're thinking, I must have lost my mind because why am I showing you a kidney? But this shows you the cognitive difficulties in making the diagnosis of SBO because this patient actually presented with right flank pain only, and the physicians were going into the room to do a renal ultrasound. So here you get a little bonus. You get to see what a normal kidney here looks like, and you can see the nice capsule kidney, the nice cortex, and this beautiful hyperechoic pelvis. No evidence for hydronephrosis at all. And then they moved on to the suprapubic region to get jets, and we're going to look at that next. So here's case number 6 continued, looking at the suprapubic region. They were trying to get jets, and these physicians saw this. So what do you think now? Does the patient have kidney stone or what? And number one, this is not technically a great ultrasound clip, but you can sort of see here this to and fro, slowed down movement that looks like bowel contents. And what the physicians did at this point was they just put down their probe, they walked out of the room, and they ordered a CT. And in fact, the patient had a high-grade obstruction and ended up having necrotic bowel and had resected bowel. And so this again shows you the cognitive difficulties with ultrasound. And so the clinicians, as clinicians, we're always up against the spectrum of disease. And here's a patient who presided with right upper quadrant pain only and had a high-grade obstruction with necrotic bowel. So what can ultrasound do for you? It can prevent disconfirming evidence that goes against your pet theory and leading you away from error. And the way I summarize this, it was actually comes from Rachel Liu, who's an ultrasound luminary, of course, works at Yale, and she told me this is how she defines POCUS. It is high quality decision making based off of low quality images. And she does not mean this in a disparaging way towards ED physicians at all, but she's talking about this case. Now, this is not a beautiful picture. Technically, it's not a beautiful picture, but it conveys important information that was critical to the case. So we can see that we got some information that said, hey, we're off the mark here. Maybe this is a bowel obstruction. So, it's patient preference. Do I look harder for the bowel with ultrasound, or I just say, hey, I nearly missed something, I'm getting a CT. This is how ultrasound can help you at bedside. So those are the sonographic findings of SPO and POCUS. And so what we're going to do now is we're going to put it all together. I'm going to present 2 final cases to you, and we're going to go through it together. And we're going to combine the elements of the clinical exam with the POCUS findings. We're going to see if we can arrive at the correct diagnosis. And not only that, we're going to see if we can effectively risk stratify our patient. And what I'm trying to show you is the power of focus. And the power of focus means an ultrasound probe in the hands of a clinician at the patient's bedside. So if you're a resident, that doesn't mean telling the ultrasound team to go ultrasound your patient. It means when you have a clinical concern or question, you pick up the probe and go in the room and ultrasound them. And maybe you should have just gone into the patient's room on patient presentation, because from the patient problem, you can tell whether it's an ultrasound problem or not. Okay, so case number 1. Here we go. Here's the history that you elicit. Here are the vital signs. Here's your physical exam findings. Here's the labs. So if we look at this, we can think of our clinical exam the same way we think of our POCUS findings in terms of diagnosis and prognosis. So if you look at this, you see history of surgery, sudden onset pain, associated nausea, and no bowel movement or flatus, obstipation and constipation. So all those are features concerning for SBO. However, you also have a patient who's tachycardic, they have guarding and rebounds, and they have elevated white count and lactic acid. So that doesn't sound like your run-of-the-mill SBO, because you shouldn't have those signs with just run-of-the-mill SBO. You're concerned now there might be some ischemia if you're listing such signs. The other thing is, notice that in this exam, the physicians actually did not record whether they found bowel sounds or abdominal distension. And this shows you the low regard the history and physical is held in today's medicine. So physicians are quite ready to order CT. However, you're not going to find them listening to bowel sounds on their patients. It's beneath them. But by doing so, you are leaving data on the table. Now let's look at the ultrasound images. So here's your clip. Let you take a look at it. So this is something you might see on your initial survey scan when you're doing your lawnmower technique, and you come across these dilated loops of bowel. And again, these may be discontinuous, so you have to look through the entire abdomen. But we see some things, in addition to the dilated loops of bowel, that may be a little concerning. So although this is short axis, it doesn't seem to be too much movement or peristalsis. And then you wonder, are those bowel walls a little bit thick? And finally, you see all this free fluid off to the left of the screen. So already you're shaping your clinical picture, which is not only is there SBO, but is it perhaps a higher grade? So here we have a still image where we're measuring the loops of bowel. So it's great to have an eyeball gestalt and feel like the bowel is dilated, but then we can go ahead and confirm that with quantitative measurement. And we see that that's greater than 2.5 centimeters. We also appreciate that free fluid there again. And then the question is, did they measure correctly? And I would say most clinicians are going to measure in the AP diameter up and down. And here we have another clip. And you're kind of wondering, what the heck am I doing here? Because I'm showing you the kidney yet again. But there's a method to my madness. And the physicians who took care of this patient were quite savvy, because I think, all of you do fast exams, and you can certainly appreciate that stripe of free fluid there. So by looking at the right upper quadrant, you're just speaking to perhaps a greater volume of free fluid, and therefore greater concern for a higher degree of obstruction. And this is actually seen in the OBGYN literature, that positive free fluid in the right upper quadrant is indicative of the need for operative repair in the setting of ectopic pregnancy. So my hat's off to these physicians who took the time to garner this additional information. Now we're going to get a clip in the long axis of the bowel, and let you just take a look at that for a second. So this clip may heighten our concern yet again. I don't know that I would describe that as we're looking at the peristalsis here, and I wouldn't necessarily describe that as to and fro, but it sort of looks slowed down to me, so a little hypokinetic, concerning for a higher grade of obstruction. All right, so the resolution of this case. CT was performed, and it was read as an SPO with some mild bowel thickening and some free fluid. It was kind of read as a low-grade obstruction. However, the surgeons were not fooled by this. Given the patient's clinical exam, they took the patient to X-lab and found ischemic bowel and resected 85 centimeters of that bowel. The cause was found to be adhesions and internal hernia. So scorecard, POCUS might have done a little better job than CT at prognosticating this patient's true condition. Okay, now our second and last case. So first you take a HPI, and this is your history. Vital signs, your clinical exam, and then finally your labs. So here, again, you can use your clinical exam just like your POCUS to both diagnose and prognosticate. So you see a patient with previous abdominal surgery, sudden onset pain, both obstipation and constipation. Sounds like pointing in the direction of SPO. And then the patient says, this feels just like the last time I had an SPO. I love it when they say that. And so very high suspicion for that. But the exam is very different from the prior one. There's no tachycardia. The patient just has diffuse mild tenderness palpation, no guarding or rebound. Labs are within normal limits. So kind of maybe giving you the feeling of a lower grade obstruction here. Okay, so now we're going to perform POCUS. Let you take a look at that. And you see here some dilated loops of bowel. Although it's in short axis, you see some peristalsis, looks fairly active. And then you're starting to see a little free fluid here. And this is actually a special sign. It's known as the Tanga sign, which is a type of Brazilian bikini because it has that appearance between the loops of bowel. So now we're starting to wonder, is this low grade or high grade with a little bit of fluid? Here we see a still image. It's great to have your eyeball gestalt for dilated loops of bowel, but it's great to confirm that with a quantitative measurement. And we see here definitely greater than 2.5 centimeters. And the physicians have correctly measured this in the AP diameter. Okay, so now we're going to turn our ultrasound probe. We're going to get that long axis of the bowel so we can judge the intestinal activity, the peristalsis. And so what do we see here? You know, is it slow? Is it fast? Back and forth? So I think you can really appreciate that this is kind of a to and fro, back and forth motion. And so this would kind of place us at least at a grade 2 decompensated obstruction. And that's kind of the gray zone of management, but one of heightened concern. Now for the resolution of the case. So CT showed a high grade obstruction with free fluid and internal hernia. Surgery was consulted and they decided to watch the patient. And the patient's symptoms actually resolved with simple medical therapy. And in this case, we'll say that POCUS was greater than CT, although it's not really the POCUS, it was the clinical exam. So the patient's clinical exam was so benign that surgery felt comfortable watching them, and it did resolve. So the radiologist has the disadvantage of not being able to talk to patients, and that free fluid was from their concomitant cirrhosis and ascites. So they had free fluid from ascites, not from a high-grade obstruction, and that fooled the radiologist. So the power focus, again, is being able to combine clinical data with the imaging results, which a radiologist is not able to do. So I'd like to just end by reviewing the sonographic features of SPO on POCUS. So what do you specifically look for when you're in the exam room with the patient? And first of all, you're looking for dilated loops of bowel. This is the hallmark finding of SPO. And conventional wisdom says it's greater than 2.5 centimeters, measured from outer wall to outer wall in the AP diameter. And it's discontinuous, so you have to do a complete exam looking through the entire abdomen before you can say it's not there. Number 2 is the functioning of the bowel or peristalsis. And you're going to say, is it normal? Is it hyperkinetic or grade 1? Is it to and fro? Now you're worried about grade 2 decompensated obstruction, or are you seeing akinetic dead bowel that's very concerning as a surgical emergency? Number 3, you're going to look at the peritoneal wall thickness. So again, no consensus definition, but normal is considered widely to be between 1 to 3 millimeters. Thin, which is in that initial stage of obstruction, it's less than 1 millimeter. And then thick in the final stages when you have a dying necrotic dead bowel greater than 3 millimeters. Then you're going to look at your valvuli. And as you saw in those two cases, this is a little subjective. So prominent and thick, yes, but how prominent and thick is concerning. So remember, you're looking for the hairbone sign going across the bowel, like fish ribs, and the keyboard side, which looks like keyboard, and both indicate that you're at the level of jejunum. And depending on how prominent and thick and hyperechoic they are, you'll have more or less concern for a high grade or low grade obstruction. Number 5 is the free fluid between the bowel loops. You're going to categorize the presence of mount. You're going to look for the Hanga sign. Consider looking at the right upper quadrant to quantify the amount of fluid. And finally, the transition point. So this is, I didn't talk about this much in this talk. CT, frankly, does a better job at identifying a transition point. Not readily seen on ultrasounds, but as you gain more experience, perhaps you will be able to identify it in your practice. Some of the studies show that it's low specificity on POCUS. So what did you learn today? First, you learned something about diagnosis. So don't miss SPO. So how do you not miss it? Perform an adequate clinical exam. So ask the right questions, perform the right exam maneuvers, and then use POCUS to modulate your estimation of disease. So yes, be good at ultrasound, but you have to be a good doctor too. Number 2, you learn something about prognosis. We learned how you can use some of these sonographic findings to risk stratify your patient into a low risk category, mid risk category, or a high risk category. Finally, here are the references I used in developing this talk if you wanted to look into things a little deeper. Thank you for your time and attention.